So first of all, thank you for the Devi Foundation for inviting me to give a talk on non-surgical management of gastric cancer. I am one of my medical oncologists currently at Moffitt Cancer Center, not too far from here. It's 4 hours by car without traffic. Got it last night with much problem. So, the topic that I'll be discussing will sort of overlap with Dr. Badgwell. I could assure you I did not look at his slides when I made my own, but there's some overlap, including the epidemiology and treatment of early disease. So, and then finally, the last section is the one that I'll be focusing on. We'll be discussing on systemic or palliative chemotherapy. So brief epidemiology, this is from 2014. There are about 18,000 cases of esophagus cases in last year with about 15,000 deaths. And stomach cancer is a little bit higher at 21,000. If you look at, depending on which series you look at, the number may vary from 20 to 25,000. And out of those, about 10,000 deaths due to stomach cancer. Overall, the outcome is very poor. Esophagus, 5-year survival is 70%. Once again, this is taking a stage 1, 2, 3, 4, everything into consideration. And gastric cancer is about 22%. Now, obviously, the higher the stage, the lower the 5-year survival outcome. So, however, this is more of a global issue. As you could see, the incidence in Asia is much, much higher. If you look at the one here in the yellow area, which is the China, the Japan, and Korea, the incidence could be high as 600,000 cases. So what are the risk factors? Once again, this is something that Dr. Badgwell covered a little bit. In US, back in 1920s, the gastric cancer used to be the #1 killer. The incidence used to be much, much higher. Okay? So question that I asked my fellow is actually a trivia question, is that what happened in the 1920s that made the incidence of stomach cancer go down? And the answer is fridge, actually, refrigerator. Because one of the risk factors for developing stomach cancer is highly salted food. And back in the 1920s, obviously we didn't have fridge, so they salted the food to make it preserved. Okay? But once the development of the fridge came out, that incidence came down because we're not salting our food. But still in Asia, they still like to intake highly salted food, which is the #1 risk factors. And obviously, the diet and high fruit and vegetables seems to reduce the risk of death. And obesity, there's some risk factor of obesity, increasing the cancer risk of the esophagus and gastric. And smoking is not good for you. I think we know that. And also chewing tobacco is not good for you as well. The important thing about gastric cancer is that this is not one disease. It's very heterogeneous, okay? So there is a different heterogeneity depending on where you live. We know that it's more prevalent in Asia because of certain risk factors. We know that H. pylori could cause gastric cancer, and there's certain variants. Certain type of H. pylori makes you higher risk of developing gastric cancer. And in US, when we diagnose someone with gastric cancer, it is more advanced than in East side. The reason is that in East, if you live in Korea or China or Japan, they screen you at age of 40. So they have a universal health system where everybody gets screened. So if you get screened early, you're diagnosed early. That makes sense. So that's probably why they do better. And there are other reasons as well. But in the US, obviously, once we're diagnosed, we usually have symptoms, and usually, unfortunately, it's too late at that time. And also, the upper GI cancer cannot be treated as one disease. Why? Because there's difference in histology. When the pathologists take a look at the slides, it's different between intestinal and diffuse type. The location is also different too. Is it in the stomach, is it in the GE junction, or is it in the esophagus? And there's also biology as well, with certain mutations, such as, which I'll go over a little bit later on, which are MET, CDH1 mutations. And the etiology, what's causing your cancer? Is it the H. pylori? Is it the drinking? Is it the smoking? So what we have learned is that there are probably three factors that plays a role in gastric cancer. We know one of them, like Dr. Badgwell mentioned, is probably maybe some bad luck, but obviously there's environmental factor, right, with H. pylori. There's also a behavior factor. If you smoke, salted food, fruits and vegetables are probably good for you. And last but not least, there is a genetic risk. And I think some of our, so I think a couple of panels here had some of the family history. So if you have CDH1 mutation, which is very rare, okay, if you have, then you're higher risk of developing stomach cancer, lobular breast carcinoma, and even colon cancer. If you have Lynch syndrome, this is the one with MMR, mismatched pair, you're also at a risk for developing other colon cancer, such as colon cancer or even endometrial cancer in female. So when we see a patient in our clinic with diagnosis of stomach cancer, this is how we stage the patient. Obviously, we see the patient, we talk to the patient, get a very good history. We do a physical examination and base labs, and we do a CAT scan, right, to rule out metastatic disease. Then at Moffitt, and I'm sure other institutions as well, we do a PET-CT. The reason for PET-CT is that it can pick up anywhere from 10 to 15% extra metastatic disease that a CAT scan did not pick up. If that's clean, we do an endoscopic ultrasound. The purpose of endoscopic ultrasound is to go in and to stage it properly. The key point I want to make about endoscopic ultrasound, this is operator dependent. So it is definitely recommended that you go to a place where this is done in high volume. Last but not least is diagnostic laparoscopy, which Dr. Badgwell mentioned. Because even despite all our techniques with EUS, CAT scan, and PET scan, we could miss up to 20% of peritoneal disease. So it is very important to get this done prior to starting your therapy. So in terms of treatment of gastric or GE junction tumor, depending on the stage will determine your treatment. If you're fortunate enough to be diagnosed with stage 1A, which is in US is not that very common, but then you go for surgery alone. However, if you're between stage 1B and stage 3, really depending on who sees you first, where you are, the treatment may vary. If you're in Asia, sometimes they take the surgery right away and adjuvant chemotherapy. That's their pattern of practice. In US and in UK, we do what we call a perioperative therapies based on the MAGIC trial, where you give chemo before surgery, then after surgery as well. Sometimes if you get surgery done up front, based on the McDonald regimen, that you give chemo radiation afterwards. And if you have a tumor in the GE junction or the esophagus, most likely you get chemotherapy and radiation up front, followed by surgery. Once again, if you have pure stomach cancer, I think data with preoperative radiation is not there. So we don't do that unless if you're on a clinical trial. And in certain patients who are not a candidate for surgery because they're maybe older or they have other comorbidity, they cannot take them to surgery, then we do definite chemotherapy and radiation. Unfortunately, if you're diagnosed with stage 4 patients, the treatment is going to be mostly palliative chemotherapy. So I'm going to go over this a little bit. Once again, this is a little bit redundant. But if you're diagnosed with early gastric cancer, stage 2 or 3, and if we see the patient first, we usually discuss it in a big multidisciplinary approach. And most of the patient would go under a perioperative chemotherapy, get chemotherapy before surgery, and get surgery, then get chemotherapy afterwards. And this is once again based on the MAGIC trial that was mentioned. And based on that method of treatment, the 5-year overall survival is 36% compared to 23% in patients who had surgery alone. However, if you get surgery up front, okay, then we see the patient afterwards. We typically follow the McDonald regimen, where you give chemotherapy first with 5-FU alone, followed by chemoradiation. Now, like I said, if you're in Asia, most likely you will not get radiation, just get chemotherapy alone. However, if you're diagnosed with a tumor that's in the GE junction or that's close to esophagus, the treatment is a little bit different, and this is based on the CROSS study. In this study, basically, patients who are diagnosed with esophagus or GE junction tumor were randomized to pre-op chemotherapy, radiation, followed by surgery, or to surgery alone. And by getting chemotherapy and radiation up front, there was higher, what we call R0 resection. The path complete remission of the specimen was much higher. And more importantly, the local and peritoneal recurrence rates were significantly lower with preoperative chemotherapy radiation. So that's the approach we use if you have a tumor that's in the esophagus or in the GE junction. However, if you are diagnosed with stage 4 disease, the treatment is chemotherapy. But once again, there's really no standard chemo. The good news is that there are multiple drugs that have activity in gastric cancer. But however, if you look at the slide, based on the region you live, it varies. If you're in Japan, they like to use a combination cisplatin and S1. S1 is an oral 5-FU drug that is not available here in the US. In Korea, they like to use cisplatin and oxaliplatin or capecitabine. In Europe and US, we like to use FOLFOX, and that's the regimen that I like to use. It's very easy to give. We have a lot of experience giving it, okay? And in some places, they give you a combination of 3 chemo, such as ECF regimen or DCF regimen in Europe, okay? And if you look at the overall survival in stage 4 patients, In Europe and North America, the average survival is about 8 to 11 months. But in Asia, it's 11 to 18 months. So you may ask, why are they doing better? Is it because they have better chemos? Answer is probably no. The main reason the East Asia patients they tend to do better is that they get more heavily treated. In other words, if they fail first line, they go on to second line. If they fail second line, they go on to third line. Compared to US and Europe, most patients don't do that. In Europe, even in UK, I don't know if it's true right now, and a couple years ago, they did not reimburse any patients who anybody who failed the first-line chemotherapy. So if you don't have money, and if you fail the first-line chemotherapy in UK, the insurance will not reimburse for any second-line therapy. I don't know if it changed recently or not, but that's it is. So that's why probably that plays a role in why the patient in East Asia do a little bit better in this case compared to patients here. So we've come a long way from chemotherapy. Now, as you know, we have this targeted therapy, where there are certain pathways that exist in certain tumors that we could target using different types of chemotherapy. And these are some of the pathways that we've studied. Okay, HER2 pathway, VEGF, which is angiogenesis we talked about, EGFR, mTOR, MET. Last is the immune checkpoint, the immunotherapy, right? This is the one that's gotten a lot of attention from the news and the media. And the immune checkpoints or the immunotherapy has been studied extensively, or they're trying to study extensively in GI tumors. And one of the tumor types this drug works is in gastric cancer, actually. So these are what we know so far. We know that trastuzumab, which is a monoclonal antibody that targets HER2, okay, works in gastric cancer. So it's a standard practice, as you know. So if you're diagnosed with the gastric cancer, your oncologist will test for HER2/neu, and if it's FISH positive or IHC3+, you get this drug in combination with a backbone. Unfortunately, lapatinib, which is a dual inhibitor EGFR HER2/neu, which works in breast cancer, unfortunately does not work in gastric cancer. And currently there are other studies going on right now using T-DM1 and pertuzumab, which I think Dr. Mitchell may cover in the afternoon when they go over the clinical trials. The other targeted pathway that has shown validity in this tumor is the VEGF pathway, is angiogenesis pathway. The first study with bevacizumab did not work in first-line therapy, but probably there are reasons that it didn't work. But in the second line, the ramucirumab, which is a monoclonal antibody targeting the VEGFR2, which is receptor type 2, has activity, and I will go over some of the data. And there's also data with patnam, which was presented at our meetings, which is a small molecule, which is a pill TKI, tyrosine kinase inhibitor, that works in the third line. So not only do we have data in using chemotherapy or target therapy in second line, we have data in third line as well. Now, obviously, the clinical trial of interest currently is the c-MET inhibitors, okay, and also the immune therapy with PD-1 and PD-L1 inhibitors. So this is sort of the algorithm once you're diagnosed with gastric cancer. You come in, the doctors will see you, and the first thing they do is they test for the HER2/neu positive. If you're IHC score 3+ or FISH positive, you get the treatment with trastuzumab or the Herceptin with some kind of backbone. At our institution, we like to use FOLFOX. FOLFOX plus Herceptin is what they will get. If they do not express the HER2/neu, and if it's HER2/neu score 0 to 1 or FISH negative, then you would just get plain chemotherapy. And once again, depending on which region you live, which cancer center you go to, it may vary from place to place. So this is just a brief overall survival data using Herceptin in first-line setting with combination chemotherapy. As you could clearly see, by adding Herceptin to the backbone chemotherapy, there's improvement in overall survival by 2 months. But they actually did a subset analysis and stating that if you're 3+ and the expression on the IHC and the tumor specimen, your overall survival is actually much greater. It's about 4 months. So the stronger it expresses HER2/neu, the better outcome you'll be when you use Herceptin. So how about treatment beyond first line? I think this is the one area we really made a lot of progress compared to 5 years ago, when if you fail first-line therapy, we didn't know what to do except to put you on a clinical trial. But now there are multiple large randomized studies showing benefit in second-line therapy after you fail first line. So there are definitely data that you could use taxanes, such as paclitaxel as a single agent, that has shown overall survival. You could use now combination with taxane plus ramucirumab. Okay, or you could use ramucirumab alone in a second-line setting, and these are the trials that I will go over, as this was mostly recently been published. There's data with irinotecan that you could use as single agent. Now, still there are a lot of unanswered questions. Question is, if you're HER2 positive, should you continue with trastuzumab beyond progression, very similar to what they do with breast cancer patients? I don't think we know that. Is there a role for immune checkpoint with vaccines or PD-1 inhibitors? So that's still yet to be answered. And also, there's a new data with some regorafenib that seems to be very promising in second and third line as well. So those are the data that I will go over. So the first study is the REGARD study, which was the first study that gave this ramucirumab approval in second-line setting. This is brand new because, once again, before this happened, there's nothing really available in second line. So these are the patients with stomach or GE junction tumor who basically failed one line of chemotherapy, and they were randomized to best supportive care plus placebo or ramucirumab, because at the time we didn't know what the standard was, so the other arm got really the placebo. And what it shows is that by getting ramucirumab in this setting, there was an improvement in progression-free survival and overall survival. So there, overall survival. And thus giving this drug indication. Now, as you know, this drug is currently available for the patients. A very similar study was done, but this time using combination with chemo plus ramucirumab. So in this study, very similar setting, in a patient with stomach or GE junction tumor, they must have failed one line of chemotherapy. But in this trial, they were randomized to ramucirumab plus paclitaxel or paclitaxel alone. And the primary endpoint was overall survival. And very similar to the other study, there was an improvement in overall survival. By adding ramucirumab to paclitaxel, there was an improvement in survival from 7.3 to 9.6 months. Okay? So in a patient who's robust, who is pretty healthy in second line, this is the regimen I tend to use in second line setting. And this is, once again, curve looking at the progression-free survival as well. Once again, clearly showing that there's a benefit of using ramucirumab with combination with chemotherapy in this setting. But however, if you look at the response rate, there was an improvement in response rate by adding this by 10%. If you look at the disease control rate, progression-free survival at 6 months and 9 months, or overall survival at 6 and 12 months, it clearly benefited the arm of the combination. However, we have to be concerned about toxicity, right? Unfortunately, we're not curing a lot of these patients. So you have to balance the efficacy with the complication or toxicity. And in this study, by adding ramucirumab to the chemotherapy Taxol, there was a higher rate of toxicity, including fatigue and neutropenia, which is highlighted, which is very important, right? Because we know that toxicity is a big concern in most of the patients. Other side effect they saw was there was more bleeding because the ramucirumab is a drug that works on angiogenesis, right, with the blood vessel growth. So there is a tendency to bleed, and this drug was no exception. Also, it causes hypertension, which is what I call class effect. Any VEGF drug used tend to cause that, but once again, this drug is no exception. So anybody who's getting this drug, the blood pressure has to be monitored very carefully. And obviously, there were other side effects that are listed there as well. So there's another drug called a patnam, which is a TKI, which also is a tyrosine kinase inhibitor, which blocks the VEGF receptor again. This was presented at, I believe, GI ASCO this year at our big meetings. This is a trial that was mostly done in Asia. Okay, this is basically in patients who failed 2 lines of chemotherapy. The data that I presented before are the patients who failed 1 line. This is 2 lines, so very advanced, right? So these patients were randomized to a patnam alone or placebo, because once again, we don't know what to do in this 3rd line setting because there's nothing standard available. And the primary and the primary endpoint was overall survival. And by taking this drug, a patnam, in 3rd line, there was an overall survival improvement. Went from 4.7 with placebo to 6.5 months. Okay, showing that this drug has activity in 3rd line setting. Once again, the caveat is that this trial was mostly done in Asia. So it's tough to extrapolate data in the US as we are all different. But once again, showing that this drug has activity, and probably a similar trial will be done here in the US to duplicate the results. The last trial I would go over that was once again presented at our big meeting is this trial called Integrative trial, which was basically using the drug called regorafenib. Some of you may have heard this drug. Is a small molecule tyrosine kinase inhibitor that blocks multiple pathways, not only VEGF, but PDGFR, FGFR, other pathways as well. And as you know, this is a drug that's currently approved for colon cancer. So in this study, the patients, this trial was mostly conducted in Korea and Australia. basically a patient who failed 1 or 2 lines, so you could have failed 1 or 2, got randomized to regorafenib alone or placebo. Okay? And in this study, the primary endpoint was progression-free survival, not overall survival. And obviously, they looked at the other endpoints as well, which are listed there. Okay, so, and if you look at just the baseline characteristics, about 60% of the patient received more than 1 line. Okay, so very similar to the other trial that I mentioned. About 60% were heavily pretreated. Okay, but most of the patient had a very good performance status. So overall, the patient looked very healthy, and this study also included stomach cancer and GE junction tumor as well. And what they found was that the progression-free survival doubled. Okay, which was the primary endpoint. The placebo, the tumor got worse in 4 weeks compared to regorafenib, where it took almost 3 months to get worse, showing that once again this drug may have activity in second or third line setting. The primary endpoint was not overall survival, but once again there was a trend towards patient living longer taking this arm of regorafenib. But this drug is not a cytotoxic chemotherapy. This drug does not cause you to have response, which we knew before. Okay, so this basically drug causes stabilization of the disease, and that's what shows here as the response rate was very low. And so this is just the Kaplan-Meier curve of PFS overall survival, clearly showing there's advantage of taking this drug, regorafenib, compared to placebo in second or third line setting. So basically the author conclusion in that study was that the regorafenib has activity in refractory gastric cancer. And it was actually very well tolerated. I didn't present the toxicity profile, but compared to other studies, this was very well tolerated. And based on that, the plan is to do a further larger phase 3 study in second or third line setting using this compound. So last thing I want to talk about is immunotherapy. As you know, this is the one that has gotten a lot of attention. So by no means, I'm not an immunologist, but I'll try to describe to you why this works. We all have T cells. Right? We have what we call cytotoxic T cells, which are T cells that kills cancer, that actually kills cancer cells, and there are helper T cells, which actually help immune response. Okay, and that's how the T cells keep our bodies in check. That's why we don't develop cancer. However, we don't want the T cells to be overactive, right? So what happens is that they have a mechanism when the T cells become activated, the T cell starts to express PD-1 receptor on their cells. So if that starts to happen, the PD-L1, the ligand from other cells, bind to the T cells and shutting it down. That's what we call check and balance system that we all have, right? But those cancer cells they're smart. They know how your body works. So what they do is that the cancer cells actually starts to express the ligand, and then they bind to the T cells and shutting it down. By doing that, it is suppressing the immune surveillance and is permitting neoplastic growth. That's basically immunology 101. So the drugs that are currently out there are trying to prevent that from occurring, either by targeting the PD-1 receptor or the PD-L1, which is a ligand. So one of the trials that got a lot of press is using the drug called pembrolizumab, which is a short for Pembro, which is basically a drug that's targeting PD-1. In this study, patients who were refractory to 1 or 2 lines of chemotherapy, okay, and they must have expressed this ligand on the tumor, PD-L1 ligand on the tumor, okay, got just this drug, Pembro, 10 mg per kg every 2 weeks, okay? And depending on if they had a complete response, partial response, or they had a progression disease, they were treated accordingly. And what they saw was that they found impressive results with this. There were patients who were responding to this drug in a second or third line setting. Not only that, when this data was presented, there were still patients who was currently getting the treatment, okay, with a long duration response. And it didn't matter if they included half were Asian, half were non-Asian, and it didn't matter which ethnic group you fell under. You still benefited from this drug. So to summarize this, 162 patients were screened, 40% did express it, okay, 65% did express the PD-L1, and 40% were enrolled. About 70% received more than 2 prior therapies. So these are very heavily refractory treated patients. There were some side effects, okay, but overall very well tolerated. But the response rate was 33%. Very high, much more higher than the other data that I've shown you. And this is not in first line, this is second and third line. And the median 6-month overall survival was at 70%. So very promising. So the conclusion of this was that this drug was very, very, very safe very tolerable. They saw durable response in both non-Asian and Asian population, which is a very key. And there was also robust anti-tumor activity. And based on this study, there are currently ongoing, there will be a trial opening up as a single agent or in combination with chemotherapy in first line. And maybe, like I said, Dr. Mitchell may cover that in this afternoon when she goes over a clinical trial. So this is sort of summary of the current targeted therapy. As I mentioned, some were positive, such as the trastuzumab, Herceptin, ramucirumab are the trials that were positive in phase 3 study. Now those drugs are available. However, there are other studies that were negative, such as EGFR pathway, they've studied was negative. There's another drug called, there's a pathway that's blocking MET pathway, and there's one drug that apparently looked very promising, but they had to stop the drug altogether because of the toxicity profile. But there's another MET compound that's currently studying, and that looks a little bit better tolerated, so we're eagerly waiting to hear those results. And in patients who are HER2 positive, there are other trials going on right now that's trying to answer the question, what can you do in those patients who are HER2 positive, very similar to what they've done in breast cancer patients. So to summarize this, I think we're cautiously optimistic, okay? We know that HER2 and VEGF is now validated target in gastric cancer. We talk about biomarkers. Only biomarkers we have right now is probably HER2, but obviously there are more works on trying to find the biomarkers for other drugs, okay? And obviously, I think the goal is personalized medicine, right? As I mentioned before, gastric cancer is not a homogeneous disease. We want to treat the patient according to maybe their molecular classification. So I want to leave you with this slide here. And I know Dr. Bass is here. He's the one that did the work, so I don't want to take any thunder away from him. But this is the cancer genome atlas. And Dr. Bass basically took about 300 gastric cancer specimens, and he did a whole exome gene sequence on this. And what he found out was that he was able to classify into 4 different subtypes. The interesting thing about 4 different subtypes is that all those 4 different subtypes had different clinical and pathologic characteristics. Not only that, they had different molecular highlights. They had different mutations. For example, if you had a subtype with EBV or Epstein-Barr virus, 80% of the time you had a PI3K mutation, PIK3 mutation. If you fell under chromosomal instability, then there may be some kind of RAS activation. So I think this is the future, right? I don't think this is ready for prime time yet, at least not in Moffitt, but this is where we're headed, where the patient comes in with advanced disease, we're able to get their tissue, do exome gene sequence to see maybe what kind of subtype they'll fall under, and to see what kind of mutation they have. And using that profile, we could treat the patient accordingly, depending on the mutation, using different kind of drugs. Thank you very much.
Thank you very much, Dr. Kim, and right on time. I'm so excited to see all this clinical research that's going on right now and the positive trials that we've had just recently. And I know this afternoon we're going to have a review of what those clinical trials are now that are ongoing. So if anybody has any questions right now for Dr. Kim, I know there was a lot that he went over right now, so I'm open to questions here. Okay, we have one in the front. He's coming around, but in the meantime, we have someone online by the name of Pat that asks, is it appropriate to take a few months off from palliative care chemo treatment?
So I think that's a question that we come up a lot of times, and then I think is yes, all depending on the patient and the patient's tumor biology. For example, if you get treated with certain chemotherapy for 6 months and if the patient has a very minimal disease and responded very well, but if the patient is suffering from the toxicity from chemo, yes, I do give temporary time off. Not indefinite time off, because we know they will come back, but depending on the situation, we've done it in gastric cancer patient, maybe give about 2 months off till the patient come back, we do another staging to see how the tumor is progressing, then restart chemotherapy at that time. So we've done it definitely it all depends on how the patient's feeling in terms of toxicity.
Great, thank you. We have a question in the front here, please. Can you please, I'm sorry, can you please use the microphone? Sorry, because not.
Whether patient qualifies for pembrolizumab, you say there's testing that can be done. What is that testing, and how reliable are the results of that testing?
Very good question. So I think depending on the trial, some trials are requiring you to express the PD-L1 expression on the tumor. So how you define expression is 1% of tumor cells or other tissue. But some trials using those PD-1 drugs are not mandating you to be positive. So you have to look at the trial and look at the inclusion criteria to see what they're looking for. But it's basically on the specimen, and how they define positivity is also very controversial. Is it 1%, you know what I'm saying, 2%, you know what I'm saying? But all depending on, in the trial design, basically.
Okay, I have another question here. What % of patients do you enroll in clinical trials, and which trial are you most interested in supporting?
So I think if you look at the academic institution, like I say, maybe different from Sloan Kettering to Moffitt, I think, unfortunately, we could do a better job enrolling patients in clinical trial, but at Moffitt, it's probably still less than 10% actually go on a clinical trial. Now, I don't know about MD Anderson, they may have much higher rate of clinical trial enrollment, but at least at Moffitt, it's 10%. I think in terms of trial, what I'm looking forward to is immunotherapy. You know what I'm saying? Like I said, I've used this drug in other disease types. And one thing is that it is very well tolerated. That's a good thing. And number one is that we've seen some good results in using immunotherapy. So I think if I had to look for a trial, I'll be looking for any kind of immunotherapy trial that is available for the patients with gastric cancer.
Great, thank you. And I'm going to ask Dr. Ilsen the same question because he's from the Memorial Sloan Kettering and is involved in quite a few clinical trials. I'll ask you both the same questions.
Yeah, I think the trial certainly has to fit the patient. Some trials have fairly specific inclusion criteria, and some have biomarkers that they're trying to pick a drug that has a higher likelihood of working in a patient. But we obviously would like to see more active clinical research. Esophagogastric cancer, I think compared to other diseases, is relatively unfunded. It is a rare cancer, so it doesn't get the vocal support of the breast cancer community and prostate cancer, where these are more common diseases. But the trial has to fit the patient, and sometimes standard of care as initial therapy might be preferred. A lot of clinical trials are being done in later line treatment. Some are phase 1 studies where the goal of the phase 1 trial is to establish the safety of the drug and not necessarily the effectiveness. So all clinical trials, I think, are appropriate depending on the situation of the patient and their physical status and whether or not they're eligible. But and sometimes a clinical trial is not always the best choice.
Yes, thank you for that. And just so everybody knows, that trial that he was talking about with pembrolizumab, that was a 1B trial, correct?
Yeah, I think the immunotherapy is a work in progress. I think it's always good to get publicity and exposure for new drugs, but we don't want to, hype the enthusiasm too much. I mean, these agents do have promise, and they appear to have modest benefit. And whether or not we need to test patients for biomarkers beforehand, we're still working on. But obviously, we have to do clinical trials to demonstrate benefit. And I would agree. I think for patients that have gone through 1 or 2 lines of standard treatment, and they're well enough and want to commit to a study, the immunotherapies are some of the most promising drugs in clinical development.
Great, thank you. We have a question here in the front.
I have a couple. I'm an example. Oh, I'm so sorry.
No, go ahead.
I'm an example of someone that took a hiatus. I have stage 4 signet ring gastric cancer, and I took a 7-month hiatus from it. Came back and got on a modified DCF. I'm doing great again. So you can take it, and it was nice to have the break from the chemo. I was wondering, could we get copies of the PowerPoint that you were doing, Dr. Kim?
Sure.
Because that would be so meaningful. I couldn't write it down enough. I had the good fortune of going to the Moffitt for the genetics department as well as seeing you, and we had genetic testing done there, and it only showed a variance in the PMI1. And then I went to iTour and had the tumor testing, and it had the CDH1 as well as 4 or 5 other mutations. And I was wondering, that seemed so unusual to me that you could have such a variance between DNA testing and then tumor testing. Could you possibly put some light onto that, why there could be such a difference?
So you had the tumor testing at the beginning. I missed the first part. So they
I
said
went to
that-
Moffitt,
Yeah,
and I had general genetic testing from a blood test,
blood test right here.
and the only thing it showed was a variance in the PMI1.
So that's a mismatch repair, right? Got it. Right.
Yes. And then I went to iTour, and I had tumor testing of the actual
Tumor, sure.
tumor. And it showed a number, it showed about 30 variances. And then, by the way, they tested for 325 known cancer genes. And I had mutations in about 5, including the CDH1. And
So I think when they draw the blood test, if you see a genetic counselor, you know what I'm saying, when they draw a blood test, I don't know exactly what they're checking. You know what I'm saying it may be different mutations they're checking. For example, one of the things that we send to them is patient with Lynch syndrome, right? That's why we sometimes, that's what we send for, and they draw blood. You know what I'm saying they're only checking those certain markers for that Lynch syndrome, and they're not going extensive testing for 30 other mutations. So I think they're more focused if you go to genetic counselor compared to the one if you send to the specimen to some I-Core or some other like foundation medicine, they do a targeted mutation of highly mutated mutation, like panels of, depending on what you look at, anywhere from 20 to 30 to a couple hundred to see which area you have mutations on. And the benefit of that is that, if you have a drug, like I said, that's targeting those certain mutations, you could potentially go on a clinical trial or using that targeted mutation. But I think, what you've tested is two different things, you know what I'm saying? So I don't think, I don't quite get the feeling that they're testing for the same mutations from the blood and from the specimen.
At Moffitt, I had 28 genes tested.
Yeah, that's our internal panel. Yes, that's
yes,
our
it was
internal.
done by Ambery, I think, and it was the CDH1 was one of the 28. And then at iTour, it was the 325, and again, it included the CDH1.
But that was not.
And so I was particularly interested, being a mother and being from a large family.
Sure.
The reason why I went to Moffitt was because of the possible connect. I could have family members that would be predisposed to having this. And so, but I'm wondering, wow, since the same gene was tested by 2 different labs, how come I got a positive from iTour and I got a negative from Moffitt? And that's
you're right. If you have CDH1 mutation, obviously there's a risk factor. The question is, I have to talk to our genetic counselor whether did they test for CDH1?
Correct.
And it was negative.
Correct.
So-
And then positive
so
at iTour.
Yeah, so maybe the methods they use, you know what I'm saying? Sometimes, they may use a different method of testing one versus the other, so maybe one's more sensitive than the other. But I would definitely, if that's the case, I would definitely take the results back and go back to see our genetic counselor, you know what I'm saying? Because you're right, if you have the CDH mutation, there may be a genetic component to this. Okay,
Correct.
so
Yeah.
I would definitely go back to the same and see why the discrepancy is. It may be because of the methods. I'm not sure about that. Yeah.
Do you coordinate with the genetics department when you provide?
Yeah. So what happens at least in Moffitt is that if there's a person who is a high risk, or we know that there maybe is a family history of a genetic component, we send them to the genetic counselor. They do all the tests and they report back to us. You know what I'm saying, in terms of what the result is. And depending on this, we do have a high-risk clinic, you know what I'm saying, and that's where the patient gets referred to if they are carrying those certain mutations, such as Lynch syndrome, you know what I'm saying, for example. They have a high-risk clinic whether it's composed of 1 physician and 2 NPs and a genetic counselor, where they'll take care of all the screening and all that stuff for you and the family.
Great.
Yes,
Yeah, we
definitely.
also have to make the distinction of what's in your germ line, like what's you inherited or what you can pass on, as opposed to what's in the tumor, because the tumor develops mutations and has things that develop only in the tumor. So that doesn't mean that you carry those mutations in your blood and in your germ line. And even CDH1 mutation, which may be an indicator of familial gastric cancer, there are also what we call sporadic. They just occur in the tumor, CDH1 mutations, that are not present in your blood or in your germ line. So that has to be the distinction. Just because you have a CDH1 mutation in your tumor doesn't mean that you have familial gastric cancer, because there are CDH1 mutations that are sporadic, that are only present in the tumor, but you have to make that distinction, and you can, so that might partly explain the discrepancy. If they did genetic testing and they didn't find it, but you have it in your tumor, that doesn't mean it's in your germ line.
Can you use the microphone, please? 'Cause-
My question was regarding the use of Cyramza and Taxol in patients who are also on blood thinners and what you have found at Moffitt.
Well, I don't think there's a, if you are on a blood thinning medication, I don't think it's a contraindication of using Cyramza. So I think, as long as they monitor it, if you're on Coumadin or if you're on low volume fragment, I don't see that as a contraindication of using Cyramza.
Great. Any more questions? We have one here.
Yes, you mentioned that there were new treatments for patients with positive HER2. Could you mention some of them, if there are any of them are in phase 2 or 3?
I'm sorry, which one? I'm sorry?
Positive
HER2
for
in
HER2.
phase
Oh, HER2. So there are other drugs out there, TDM01, pertuzumab, which are the drugs that have shown activity in breast cancer who are HER2 positive. So those are trials that are currently ongoing right now. We don't have results of that. The fact that it works in breast cancer HER2 does not mean it will work in HER2 positive in gastric cancer. So for example, patnam, which is a drug, dual inhibitor blocking HER2 and EGFR, worked in breast cancer but doesn't work in gastric cancer. So there are drugs, the TDM1, pertuzumab are the two main drugs that are currently being studied in patients who are HER2 positive gastric cancer.
Do we have any more questions? Okay, great.
All
Well,
right,
thank you so much. Oh, we have one more in the front, sorry. Microphone. Can you please use the microphone? Thanks.
You got testing for genetics in blood and then in the tumor itself. Which is more important?
Well, I think like Dr. Ilsen mentioned, I'm saying depending on, if are you looking at the mutation of tumor, or are you looking at hereditary risk factors? I'm saying.
We don't know yet.
Yeah, so I think that's why, mutation in tumor cell does not mean you will carry it in your germline, you know what I'm saying? So you have to make decisions of what you're looking for. For example, if you're looking for a trial, let's say, okay, for a trial looking for certain targets, you test your tumor cell, right? You send that tumor to whatever to see what mutation you have and not test your blood, you know what I'm saying, for your germline. So there has to be distinction in terms of what you're looking for when you do that.